So why don't we go into kidney and go right back to that space? There's some perioperative data, but probably the big one we wanted to see was the readout from RAMPART.
Yeah, so I think, if we're trying to think about how this meeting advances us, this is an incremental kind of meeting, right? This isn't one of those, groundbreakers, big steps, but this is, I think, incremental knowledge that helps us understand the disease a bit better, plan future trials and plan future interventions better. And that's probably across kidney cancer. So back to the context you laid, which is, the peri-op setting, adjuvant therapy. We've had a real mixed bag here, right? A couple of negative trials. The one trial, Keynote 564, that stands out as a positive trial, positive DFS, positive OS, access, reimbursement. I think it's part of our clinical practice, and we'll talk about that a little bit more. But every time we've seen a talk on adjuvant to date, there's always been, but we will await RAMPART. And we don't have to await RAMPART anymore because the first results were presented by James Larkin here at ESMO 2025. And so to contextualize this is a phase 3 RCT of using adjuvant durvalumab, either as monotherapy or with tremelimumab in resected RCC. This is a slightly complicated trial, to be totally honest. So, we're looking to enrich a surgical cohort for patients who we think are likely to have recurrence events and therefore may benefit from adjuvant therapy. In this context, they're using the Leibovich scale that's, derived from Mayo Clinic.
What do you think about that? What do you like to use?
Yeah, so I think it's totally reasonable. There's many ways to skin a cat. And this is one of those situations where I don't think there's a clear best approach here. Some people will use a UISS kind of score. Some people will use the Assure nomogram. I think Leibovich is very reasonable. Honestly, I find the Assure nomogram very easy to use, easy to access online. Put your patient's parameters in. They'll give you a nice predicted outcome that you can use for counseling your patients. But I think regardless of what tool you're using, the key is that post-resection, post-nephrectomy typically here, although occasionally partial nephrectomies come into this space, you need to be thinking about what's my patient's chance of recurrent disease and might they benefit from adding some adjuvant therapy. And so as long as you're thinking in that context, I think we're headed in the right direction.